Okay, so now we move on to the selected abstract from Ajlan Zaki from UPenn. He's going to talk about a multifunctional nanoparticle platform and in vivo application. Go ahead.
All right. Good afternoon, everyone. My name is Ajlan, and I'm a graduate student in Andrew Chalkas's lab in the Department of Bioengineering at the University of Pennsylvania. And today I'm going to tell you about some research that I'm doing for my PhD thesis. The title of the talk is a multifunctional nanoplatform for imaging, radiotherapy, and the prediction of therapeutic response. So when I think of X-rays, it usually evokes a feeling of being unwell, of being in the hospital, in a gown, getting ready to take a CT scan or an X-ray scan. And for the younger folks here, when you think of X-rays, you might think of going through the body scanners at the airport and doing this sort of, pose. Now, for the older generation here, and I have to put it in all these perspectives, you might think of it in this scenario. So in the late 1800s, when X-rays were first discovered, they were used primarily for entertainment purposes. So there was an X-ray mania. Everybody wanted to get X-rays of every part of their body that they could. They'd have these born portrait imaging studios, and they were also used in the retail industry. So you go into the shoe store, and the seller basically says, well, put your foot in this scanner here, and let me see if your foot fits perfectly into the shoe. Now, of course, this isn't used today anymore. However, till this day, it remains an important cornerstone in cancer treatment and management, where approximately 50% of all cancer patients will receive one form of radiation therapy or another. And the radiation therapy essentially delivers high energy to cancer cells. And the main goal here is to deliver this high energy to deprive cancer cells of their mitotic potential. So if they're not dividing, they apoptose, and eventually the tumor remits or regresses. So these two mechanisms here are essentially the roots of DNA damage using high energy radiation, ionizing radiation. So either direct or indirect through the generation of free radicals. And the main objective is to inflict enough damage to generate DNA double-stranded breaks. Now, if there is insufficient DNA double-stranded breaks, the cancer cell is able to repair itself and continue to proliferate. However, if sufficient DNA damage is inflicted, this deprives the cancer of the ability to repair itself, enabling it to undergo cell death and ultimately regression. And there are other agents that can be used to enhance the effects of ionizing radiation, such as oxygen, curcumin, and gold nanoparticles. And these basically complement the effects of ionizing radiation. Now, this sounds trivial. Okay, why don't I just blast a cancer cell with a huge dose, a whopping dose of radiation, and get rid of it? Well, the problem here and the hurdle is you have to spare healthy tissue, right? So in this image here, a pre-contrast image of the brain, one can't really discern or notice the dimensions of the cancer. However, and therefore, when you're administering radiation, you're inevitably going to be exposing normal tissue to radiation damage. Upon the administration of a contrast agent, however, if you look at this post-contrast image here, the tumor lights up. So you see the tumor morphology, you're able to discern the boundaries, and you're able to tell this is normal from diseased tissue, increasing the therapeutic window here, maximizing radiation dose to tumor tissue while sparing normal tissue. And so, of course, there are other strategies that are used and implemented in the clinics to reduce and increase reduce the toxicity and increase the therapeutic window, such as fractionation, improved delivery systems, treatment planning softwares. For this talk, we're going to go primarily with imaging. So the system we developed is a polymeric micelle consisting of gold nanoparticles and an amphiphilic diblock copolymer, a hydrophobic and hydrophilic component. And the advantage of this gold polymeric micelle is that by incorporating this polymer, it essentially is biocompatible. And in essence, you're also able to carry other drugs, hydrophobic drugs, within this hydrophobic compartment, as well as other imaging agents. And the surface of the particle makes it amenable to functionalizing these particle for cell-specific targeting. So first thing, we're going to develop a platform or a method to synthesize these micelles. Then we're going to test them in vitro, their radiosensitizing effects in vitro. And from in vitro cell lines, we're going to move into an in vivo mouse model, injecting them into the mice, acquiring CT images 24 hours post-injection, and then using the contrast enhancement within the tumor here. Hopefully, there's enough gold accumulation, using that as a guide for radiation therapy. So image-guided radiation therapy using this gold-generated contrast in CT imaging. And so before we move on to any of that, I want to show you the particles that we're able to create in the lab. And we're able to generate sizes, various sizes, ranging from 25 nanometers all the way up to 150. Relatively monodispersed, highly packed clusters. And if you can look at this image here on the bottom left, it essentially is a cryo-TEM images. So an image of the particle as it would be, or as it would appear in solution. Very tight cluster of gold. It doesn't seem to be really packed in any unorganized fashion. Actually, they seem to be packed in a very well-organized, well-ordered manner. And I don't know if you can see this, but there's a sort of a membrane around it. I don't know if you can appreciate it here, but there is a membrane around it which is consistent with the pegylation on the surface. So once we have these particles, we wanted to assess their radiosensitization effects in vitro. So we use this fibrosarcoma cell line and stain for gamma H2AX, which is a marker for double-stranded DNA breaks. And if you look in the absence of radiation, there really is no difference between the presence and absence of gold. However, when we do add gold and radiation, we see an increase in the number of foci, the focal spots here, consistent with an increase in double-stranded DNA breaks. Quantitatively, there's actually a 2.2-fold increase in the amount of double-stranded breaks compared to radiation alone. So before moving on to doing survival in mice, we decided to characterize the pharmacokinetics. How long do these particles circulate? Can we use these particles for contrast imaging in the blood pool? And actually you can. If we look compared to the pre-contrast image here, 30 minutes post-injection, the chambers of the heart brighten, as well as the abdominal aorta. And you can actually, if you really pay close attention, you can actually look at the microvessels here, the interlobular arteries of the kidney. Now, as we go further away from 30 minutes, there's still some contrast present within the heart as well as the vessels. Ultimately, 48 hours, this contrast seems to wash out, and this is consistent with other studies reported as it's sequestered into the liver and spleen by the reticular endothelial system, so back macrophages in these organs. The pharmacokinetics as well of the clearance profile or the elimination profile has a half-life of around 6 hours. And so the main question we wanted to see here is, okay, we can see it in the blood vessels, we can see it in the major organs, but can we actually see it within tumors? Because what we wanted to do is use the contrast within the tumor to guide radiation therapy. And the answer is, indeed, we can. So compared to the pre-contrast image here, 30 minutes is not enough, but 24 hours post-injection, you see that there's an increase in contrast consistent with an increase in accumulation of gold micelles. And you're able to appreciate the boundaries of the tumor, ultimately allowing you to delineate tumor tissue from normal tissue. And this here is a biodistribution of the micelles, and of course, consistent with many other particles of this size range, the primary accumulation is within the reticular endothelial system, liver, and the spleen. However, we do get some accumulation within the tumor, and enough accumulation to actually see it on CT and administer radiation therapy. So what does this look like in a survival model? Well, if you, I don't know if you can see this. Okay. Sorry for that. Basically, if you look, the curves basically, there's no comparison between radiation or gold only. But if you want to compare radiation therapy with gold micelles plus radiation therapy, there's a 1.7-fold increase. These curves never overlap with the radiation therapy group. And eventually, 30 out of 7 mice survived up to 90 days for the gold micelle plus radiation group compared to 1 out of 7 for the gold micelle, for the radiation group alone. So this was pretty interesting. I mean, we thought these were pretty substantial results. The problem with using gold is that in order to see gold on CT imaging, you need to administer high doses. So the therapeutic dose and the dose required for imaging are mismatched. So we wanted to bring that dose that we needed for imaging down. And so how do we do that? Well, we decided to change it by modifying the platform by incorporating 12 nanometers SPIO particles, so superparamagnetic iron oxide particles. And these particles would enable us to assess the tumor contrast using magnetic resonance imaging, T2-weighted magnetic resonance imaging. And so the advantage of this platform compared to a gold-only platform is that now we're able to exploit and take advantage of the higher sensitivity of MR compared to CT. And we're going to go through the whole protocol again. All right? So the size we selected for these studies were around 100 nanometers. We're able to generate sizes similar to the gold-only Micelles, ranging from 25 to 150. And if you look at this video here, if I can play it, what you see is it's essentially a TEM of a micelle incorporating gold and iron. And so I took a slice section of TEM. It's like a CT scan, but on a particle. And you can see two different sizes of particles. These large particles here, iron, and the smaller gold particles incorporated within the iron. So this was just a proof to show that, yes, we do have iron incorporated within our gold, or two different size particles. Because this figure here on the bottom shows that we have an iron signal and a gold signal using energy dispersive spectroscopy. So this is characteristic to iron signal and gold. This here just shows us two different size particles. And so if you remember, I told you the reason and the motivation for incorporating iron into our micelles was that we wanted to overcome the sensitivity limits of CT. So what is the sensitivity limit for using CT imaging? Well, for gold polymeric micelles, the limit of sensitivity with statistical significance is around 1,000 micrograms per mil, 1 mg per mil. Well, what about MR? Well, MR on T2-weighted imaging, that's why it looks darker here, the limitations or the sensitivity limit is around 15 microgram per mil. So already, by incorporating iron into our micelles, we have a 66-fold improvement in sensitivity compared to using CT alone. So we can administer lower doses for our mice to perform radiation studies. And so similar to what you've seen before, these gamma H2AX studies, there's really no difference incorporating iron into the micelle compared to the gold-only micelles. And of course, they're significantly higher than radiation only. And of course, the gold standard for these studies are colonogenic assays or colony-forming assays. And we see that as we add and incorporate GSMs, the colonies surviving actually are much less than the colonies that you would see with radiation only. And I don't think it's included here, but it's a 1.3-fold, or surface enhancement ratio of 1.3. And similar to the other platform, the accumulation is primarily within the reticuloendothelial system. Again, we do have accumulation within the tumor and lymph nodes. And the circulation half-life here is, however, 3 hours. Okay. So I told you that the reason why we did this is because we wanted to use MRI imaging. We wanted to lower the dose so we could basically avoid injecting unnecessary amounts of gold into mice. And so what do we see? So by lowering the dose, can we distinguish any increase in contrast 24 hours after injection? And as you can see, you really can't. There's really no difference pre-contrast on CT imaging compared to post-contrast. Whereas if you look at MR here, 24 hours post-contrast, you see a hypointense area within the tumor, indicative of gold nanoparticle or gold iron micelle accumulation. So already we were able to decrease the dose, appreciate the accumulation within the tumor, and this is via EPR effect using MR. And so for the survival studies, this one came out a little bit better. Really, there's no difference between the control groups, no treatment, or gold iron micelle group. Whereas you see here, for the gold iron micelle group, 5 out of 7 survived compared to 2 out of 7. And I have to note that 2 out of 7 in this duration still had palpable tumors, whereas all 5 of these mice had complete remission, non-palpable tumors. And so we decided to take it to a further step. So this is really interesting. This is really good, really cool results. But we wanted to sort of correlate. Can we use imaging to correlate therapeutic response? Can we use an image to tell us and predict how would a mouse respond prior to the administration of radiation therapy? How it would respond? And so we were actually able to do that. And so what you see here is there's a linear correlation between the amount of contrast in the tumor to the rate of tumor decrease, or to the therapeutic response. And so what we attribute this to is that because there's more contrast within the tumor, that ultimately means that there's more nanoparticles. Because there's more nanoparticles in the tumor, there's more radiosensitization. And more radiosensitization, better response to treatment. So let's see if I can show this pictorially. All right, so this here is a 24-hour post-contrast image. I've included the 24-hour, the pre-contrast image just for reference. And what you see here, this mouse here has a more hypointense 24-hour post-contrast image compared to this mouse here. This mouse, it ended up responding better to radiation. The tumor decreased faster compared to this mouse here with a slower response. And so while we attribute the more nanoparticles being the reason, we can't give it all the credit. The other area that you can sort of give credit to is because these tumors have more nanoparticles, they could be more permeabilized. They could have a better oxygen supply, better blood vascular supply, increasing the oxygen-mediated effects of radiation-induced toxicity. And so I hope through this talk I was able to convince you that the gold micelles and gold iron micelles improve survival in murine tumor xenografts. They enhance, as well as enhance radiation-induced damage in vitro. Incorporating iron into gold allows for improved sensitivity using MR. And finally, the gold-iron micelles correlate with the therapeutic response, the rate of tumor decrease. And of course, I'd like to thank my advisor, Andrew Chalkis, Casey McQuaid, who is a medical student at the University of Pennsylvania, who really has been a tremendous help through most of these studies. And of course, our collaborators in the Department of Radiation Oncology at Penn, Department of Chemistry. And I open the floor to any questions. Thank you for your attention.
So we have time for one or two quick questions. Well, I can ask questions. Hey, so looking at the distribution of your nanoparticles, right? Mm-hmm. So basically, if they don't cover the entire tumor, the effect may be very limited. Does that make sense?
Yeah.
Yeah. So that's what you showed in the.
You're saying yeah.
Yeah. So, but basically, what you show is where they accumulate, where there's a lot of permeability, but the tumor extends beyond that range, mm-hmm. right? So how would you deal with that?
So that's definitely an important question, and we need to do 3D treatment planning. So the way it's done in clinics is they basically take a 3D image reconstruction of the patient, and they're able to do treatment planning around that volume. I think ultimately it's a big challenge because you're not able to get accumulation within the whole tumor. So you're probably going to be ending up, missing part of the tumor. And so that's where other...
Yeah, because as compared to a drug that can be released from a particle and then diffused throughout the entire tumor, you don't have this strategy. Okay. So the other things, like, can you disclose anything about the formulation process of these micelles?
Yeah, it's very simple. It's essentially like making balsamic vinaigrette.
Okay.
It's you take an oil, you take water, and you just mix it up together. You sonicate.
And there's no further purification?
Well, there's purification. There's diafiltration. There's centrifugation. There's 0.2 micron. There's radiation.
I guess we can finish now. Yeah. But maybe there's some salad and he can make a dressing.
He's gonna next time we're inviting him to make the cooking here with us. Thank you so much.